Hello.
Yeah, doc.
Yeah. I'm making you the host and I'm leaving.
You already done the streaming part.
Yeah.
So when do I start the webinar? ये attendees के लिए कितने बजे अपन ये start करते हैं?
You can start. You ask these guys, na, that should we open the room?
Okay. So
Or
typically
you
about
start.
10 minutes prior we do that.
See, listen. Don't ask anything. Start at 9:55, and maybe after that you can tell them that you all are audible and visible to the audience. ताकि वो लोग कुछ
Okay.
वैसा ना बोले.
ठीक है. Done.
हाँ, thank you. I'm leaving from here. Huh? Hello. Hello.
Yeah, doc. No problem. No problem. Sorry, I was
Yeah.
muted.
Okay, bye.
Okay. Morning, sir. Bhavesh here.
Good morning. Good morning.
You would like to share your screen
Yeah,
and it out
yeah.
once?
The problem, I have to share my screen. For that, you have to make me the host or something like that, so that I may be able to share my screen. Now I am joined as an attendee.
So you,
Could you hear me?
you are allowed to share your screen. You can share the screen because I have not opened it for attendees to join.
Okay. All right.
We are still in the
When
practice
you
session.
open, I can join now. Straight away with share screen.
Yeah, you can
Yeah.
do that.
Okay.
Hello, sir. Madhusudan, sir. Good morning.
Good morning. Good morning. I cannot see you, but why don't you open your video also?
See, you are the person who is to be seen, not me. It depends on who is the star.
No. It's always good to see your face, no? So that there feels acquaintance. Rather
So
than
how are you,
hearing
sir?
the voice, seeing the face is more present.
Okay, sir. Hi, sir. Can you see me now?
Yeah.
So, sir, how are you? Good.
Doing fine, no problem.
Now you are doing your routine clinics?
Yeah, not in the house. I used to practice at home. That I stopped now. I'm going to hospital every day from 10 o'clock to 2 o'clock and come back.
And you don't go to, do you go to ICUs and all?
Yeah, I go to ICU. Everything. I got inpatients there. Not many as before, but few inpatients.
So is it, I mean, there is no corona in Kerala now?
Plenty. In Trivandrum, it is in thousands. It is in 6,000 yesterday, day before yesterday.
So do you think with proper precautions we can avoid getting corona?
I don't know, so but whatever it is, I go there with that full kit and all. I put the gown, gloves, shield, everything, mask, everything I put, and then only go. And after seeing every patient, I make a point to wash my hands on the coat where the patient was lying. Cumbersome, but no other go. What about you?
We are going on. See, Dr. Sita got COVID. You know,
See that?
she got COVID. She was
Oh,
admitted.
oh.
So means we we are we are affected. Dr. Sita got COVID. She got treatment also. Now she's back to work also. In fact, it is better to get COVID and come out of it.
Correct. I'm out of it.
But then only thing is once you get, you are not sure whether you will come out or not. Particularly at our age.
Exactly. It is like a
Sita
chicken
is
pox.
10 years younger than me.
Yeah.
So, but she fought it. She's a fighter, so she came out. Now she's working. I'm going on alternate days.
Okay.
It is just statistics that, okay, 50% exposure is less. And I'm not going to ICUs and all as of now.
Okay, right.
Many people are dying here, Madhusudan. Many people are
Can
dying.
I open the webinar for everyone to join?
Yeah.
Yes.
Good morning,
Yes, we
Sunil.
are ready. All the best.
Thank you. Hope it will be good also for you. It is not meant for you, Subhash, meant for junior people.
Yeah. Now, hospitals have come to know that they can manage without senior people. They did not know that before. Madhu?
Yeah.
Actually, I was thinking, but actually all your talks are very informative.
Yeah.
Actually, I was conceptualizing some webinar,
Yeah.
myself also as a speaker and yourself also,
Yeah.
and one or two more speakers for, because I have heard those those talks before, like the mistakes I have made,
Okay.
we learn. And
Yeah,
I'm sure, but what I realized is that in many of these routine cases also you make a reference to that you missed something and how eventually many of
absolutely.
your cases I
Yeah,
have noticed that,
yeah, absolutely. This is the case which I'm presenting. The way I have seen, I have thought about it, where I have gone wrong, all I will present. Then
But
only,
Madhu,
yeah,
there will be a difference between your mistakes and my mistakes.
yeah.
In your mistakes, finally you realize in time, and the patient survives. Because of my mistakes, patients have died also. But it was not intentional.
But I am not dealing with strokes. That's the problem.
I mean, there have been serious mistakes,
Yeah.
but trust me, they were not because of lack of knowledge. They were because something didn't occur at that time.
Absolutely.
Something has to occur at that time. That is the whole clinical medicine. Knowledge alone is waste.
Hmm.
Application.
Okay.
Okay, Bhavesh, can we start?
Yeah, start. Sure, no
Okay.
problem.
Okay, sir.
Hello.
Yeah.
Hi. Hi, Mansi. Our music talk got postponed.
Oh, okay.
So today there's a neuro talk only by Madhusudan.
Okay, okay. All right, sir. Not a problem.
Okay, Madhu, I think you can go ahead, yeah.
Yeah.
Okay, sir, I have just opened the room so that participants can log in. We can wait another couple of minutes
Yeah.
till we have a few participants and then we can begin.
But Mansi, is there any other talk after Dr. Madhu's talk?
No, sir.
Okay. Because what
I
happened,
have been
Mansi?
informed is it was only the musical talk.
No, music talk has been postponed.
Yes, with Dr. Shirish Hastak was also involved in that. Is that
Yeah.
right?
No. Roop told us
Yes.
yesterday it is neurology has a priority on music.
Okay.
So the thing is that no, it's okay. If there is no other talk, then Madhu can go on after 11 also.
Okay.
Yes.
Otherwise, we are always pushing, stop it. So,
Yes. Madhusudanan sir, can I request you to share your slide?
Yeah, yeah, right. For that, you must make me a host, no? Yeah,
Sorry, sir.
okay, right. I can share my slide. Are you able to see my slide now?
Not yet, sir.
Now?
Yeah.
Yes.
Yes.
Okay.
Good morning.
Good morning, Sudhir. Good morning.
hi, good morning, Sudhir.
Hi.
Okay. Good morning to all of you. At the outset, I would like to thank Sudhir and his team, Dr. Subhash Kaur, for making me part of this program. This is the fifth part of the grand rounds. The pattern is exactly the same as before. I'm going to show the case history and findings, and I'll be asking questions to you. Those who want to answer can unmute themselves and then give their comment, and then mute again so that when the other people can hear. So I'll go with the first case. This is a story of a 75-year-old diabetic. Any problem? Are you audible to you?
Yes, go ahead.
This is a story of a,
You can just make your camera a little down so we see more of you. Fine.
okay, thank you. Is it okay now?
A little, no, now, a little higher, slightly. We want to see, no, higher. We are seeing your chin. Yes, perfect.
Okay, thank you. This 75-year-old diabetic man presented with history of fatigable weakness in lifting both shoulders, 3 months duration. Drooping of head forward on prolonged sitting and standing. His head will come forward like that for 2 months duration. Occasional drooping of the jaw, opening of the jaw for two months, and difficulty in getting up sitting position for the last 1 month. So fatigable weakness of lifting the shoulders, drooping of the head forward while sitting and standing, occasional drooping of the jaw, and difficulty in getting up sitting position. This is the video of the patient. What you can see is he has got, you can see his mild ptosis bilaterally. Horizontal movements are okay, mild slowing probably, but the vertical movements were affected. He could not look up nor look down. Now come to the rest of the examination. Orbicularis oculi was mildly weak. I can easily open it without any problem. Coming to the lower canal, this opening of the jaw is weak. Lateral pterygoids were weak. Coming to the tongue examination, there was no wasting of the tongue, but I could make out some occasional fibrillation, on the sides of the tongue. You can make out here, somewhere here, on both sides. But there was no wasting, and the tongue movements were normal. You can make out some fibrillation on the side of the tongue. Tongue movements were, however, were normal. Neck flexors were weak. Go to the motor examination. He has got about 8, I'll tell the power later on. He could not keep his hand upright like that, it falls down. The power was about 4 to 4 in both flexors, the elbow. Neck flexors were weak. The lower limb is also weak proximally. Flexors were weak. Oh, the distal muscles are quite okay. Come to the reflexes, they are all quite brisk or well elicitable reflexes. 2 plus, all present 2 plus, not absent. Angiojecs are absent because it's a diabetic. Pandaurus flexor. So these are the findings. I'll tell the finding once again. He had restriction of all ocular movements, mainly vertical, mild ptosis, but not fatigable. Weakness of orbicularis oculi, weakness of lateral pterygoid. The jaw opening is weak, closure is strong. Fibrillations in the tongue, but no wasting. Tongue movements normal. Come to the motor system, about grade 2 to 3 power of proximal muscles of the upper limb, grade 3 to 4 in the distal muscles of the hands. The lower limb, grade 4 power of proximal muscles, grade 5 distal. The weakness in the upper limbs were fatigable, which you already saw. DTR were all 2 plus except for the angle which is just elicitable. Plantar's flexor, sensations, no. No, I did a fatigue test for his speech also. I was asking him to repeatedly say 66. You see, so you can hear his speech.
66, 66, 66, 66, 66, 66, 66, 66, 66, 66.
Initially, it was like this.
66, 66, 66, 66, 66, 66, 66, 66, 66.
Towards the end, it became, instead of 66, it became 60C. It's a little more fatigability of the speech. Now, what is your diagnosis now at this point of time? What is your thinking now? You know what I thought? If anyone want to make a comment, you can make a comment at this point of time.
Okay, so seems like a neuromuscular disorder, of course, but it's unlikely that you will show myasthenia again. So I don't know, it may be something different. Maybe it's not common for Eaton Lambert to have ophthalmoplegia and things. So, but maybe possible query Eaton Lambert, query some sort of paraneoplastic thing causing Eaton Lambert, but
Yeah, perfect. The same is the same thing which I also.
Relations in the tongue are a little confusing. I'm not able to see how that can be explained.
There are some fibrillations in the tongue. That is the odd point. Etienne Lambert was also considered, but the reflexes were quite brisk. I expected any absent reflexes.
Yeah.
But I would also keep a possibility of early MND.
MND, okay. MND can have fatigability, as you said
Yeah,
correctly. The
ophthalmoplegia,
ophthalmoplegia was
ophthalmoplegia is a
not,
little point against MND, not very common to get ophthalmoplegia, but the
yeah.
ptosis is also not fatigable. So I don't know whether we are dealing with some sort of query brainstem lesion, but there are no long track sign, nothing. So I would put it as neuromuscular.
Yeah, that's the first possibility I also thought. So let's see the possibilities I can get. Myasthenia as declared antibody positive myasthenia, antimus is considered a little more strongly because of the secretions in the tongue. Eaton Lambert is the other possibility I considered. So I went ahead with the investigations. Let us see the NC is also diabetic. I would like to remain that point. Now, left median CMAP was not elicitable. Right median was low amplitude. Mild decrease in the right ulnar CMAP. Come to the lower limb, left peroneal CMAP was decreased. Come to F5 latencies, both median and ulnar nerve, they were absent. Come to the sensory, left median not elicitable, left supraperoneal not elicitable, and both swirl were mildly decreased. So in NCV summarizing, no potentials picked up from the left median nerve, decreased CMAP amplitude from right median, right ulnar, left conperoneal nerve, no snap from the left median and superficial peroneal, decreased snap from both swirl nerves. In fact, I did not give much importance to these potentials because he's a diabetic. He can very well have, say, for example, carpal tunnel syndrome and mild pressure pulse with the conperoneal. So that did not gel with the clinical finding. So this is the NCA finding I got. So I did an RNS, showed decremental response in all the three muscles I checked. This was in the trapezius, it was decreased, showed decremental response. So also in the facial, so also in the ulnar. So you can make out the both. This is especially obvious after exercise. See, after exercise, 1 minute it is 18 to 18% or so. Then become progressively worsen. Again, the other muscle, it become up to 32 in some of the muscles. Decrement. All muscles show decrement in following post-exercise. This is another muscle after exercise. So RNS from ulnar, trapezius, and facial show decremental response after exercise. So I did another test I did was to rule out Eaton Lambert syndrome. The CMAP amplitude did not increase after 10 second exercise in the right median and peroneal nerves. That is the nerves with low CMAP amplitude. We got two nerves with low CMAP amplitude. That nerves I did the after 10 seconds exercise repeat CMAP evaluation. There was no increment in the amplitude of the CMAP. That is against the Eaton Lambert syndrome. Now, what is your impression now? It was RNS was positive. Myasthenia. Let us consider the possibilities now. Now, what about the RNS diagnostic specificity? A decremental RNS is not specific to myasthenia gravis. It may also be seen in LEMS, which is really uncommon and less likely now. Motor neuron disease like ALS, myopathies like McArdle's disease and myotonia. So CT test was done. There was no thymoma. The antibody was sent because myasthenia was strong in my mind. That came as negative. Then asked for anti-musk antibody. Unfortunately, the patient could not be done. This could not be done because because he could not afford that test being a private hospital. So what do you want now? So I did a new statement test to say if I find out whether it's really myasthenia or not. But that came as negative. So we are some points favoring myasthenia, some point not favoring myasthenia. Now, what do you want now? What is your thinking now?
Single fiber.
Pardon?
Single fiber EMG.
Yeah, but I have not done single fiber EMG, nor I am an expert in that. I only seen being done. But I go for more less sophisticated investigations. Anyway, I did not do that anyway. But neostigmine was negative. That's my strongest point against myasthenia.
But last case, Madhu, you showed that
Yeah,
injection
perfect.
neostigmine was negative, but tablets worked.
You're
Last.
perfectly right. You're perfectly right. So that does not rule out anything. That's actually the points. So let's talk about two sentences about anti-musk asthenia. Musk asthenia predominantly affect females, begins from childhood through mid. That is the strongest possibility considered in this. In some patients, the clinical findings are indistinguishable from acetylcholine receptor antibody positive myasthenia with fluctuating ocular, bulbar, and limb muscles. However, many myasthenic patients have predominant weakness in the cranial and bulbar muscles, frequently with marked atrophy of these muscles. Others have prominent neck, shoulder, respiratory weakness with little or no involvement of the ocular and bulbar. This is from the literature showing the trifurrowed tongue in anti-musk myasthenia. Now, thinking back, can be our patient having ordinary myasthenia gravis? The points against neostigmine test is negative, but as counts, it need not necessarily be positive all the cases. May be positive only in 80% of the patients. The other point against myasthenia is tongue fasciculations. Now, then went to the literature to find out can fasciculations occur in myasthenia gravis. There is sufficient literature to tell rare presentation of tongue atrophy with fasciculation in myasthenia gravis. This is another case where it was diagnosed thought to have bulbar MND because of the tongue wasting. Then there are no response to neostigmine test, but ultimately turned out to be bulbar myasthenia. So it can be easily confused with motor anticonvulsive disease. Now, why not anti-musk myasthenia? One of the points favoring is very early facial and bulbar onset. Tongue fasciculations can occur. A negative neostigmine test does not exclude anti-musk because the positivity is only 60% compared to the positivity in anti-acetylcholine receptor body myasthenia, where it is 80 to 90%. Now, why not Eaton Lambert? Because there is no increase in the CMAP after 10-second exercise. But other points against the age of onset is usually the mean age is 40 years. Except more in females. Even the fasciculations are seen, there is no wasting of the tongue. So these are the points against Eaton Lambert also. Now, what will you do in this patient? I've exhausted my investigation. So anything else you would like to do before starting treatment?
CT chest, sir?
CPK was normal.
No, sir. CT chest, sir. CT chest.
CT just told initially it was normal. There was nothing. I think I showed the picture, slide, I think. Okay, no, but so I compelled to start neostigmine in this patient, but we had no definite confirmatory to spinal junction disease, even though RMS was positive. So just like as Sudhir was telling, early mid-brain lesions can present like myasthenic symptomatology because well-known tectal lesions can produce. Just the last the one talk two weeks back, I had shown this point. Early brainstem lesions can present with myasthenia. See, these are case histories: tectal plate glioma presenting a generalized myasthenia in adult, pseudomyasthenia in a patient with pontine glioma, B-cell lymphoma of the brainstem masquerading as myasthenia, and vertebral aneurysm causing brainstem compression mimicking seronegative myasthenia. So did I see MRI brain is normal. So that possibility is ruled out. Now what will you do now?
Trial of isostigmine and steroid, sir.
Yeah, that could be done. But since there is fasciculations of the tongue, I want to look motor neuron disease with myasthenic symptoms. Can be motor neuron disease. Positive RNS is well known in MNT, is already told. We reported 40% of the ALS patients positive RNS. However, ocular muscle involvement is odd, rarely it is described. And the fatigability is very convincing on history and examination. Even though RNS is usually positive in myasthenia, fatigability is not that common in myasthenia. Clinical fatigability is not that very common.
Was
But
there any upper motor neuron sign anywhere?
no upper motor neuron. Reflexes are really excitable, but no plantar so downgoing, no spasticity anywhere.
Okay.
So I'm
The
thinking of
EMG, sorry sir, disturbing. EMG was done, sir, of the tongue, sir, needle EMG of the tongue, sir, and
yeah,
paraspinal muscles.
yeah, correct. So I went ahead with before that, just tell them on the just to reiterate the fact that RNS can be positive in MND. These are the literature support. So I did the EMG from the deltoid. Reflex information. You can see the stimulation, circulation, gross only one or two more pains to carry. So I did it from the FDA, which also showed I wanted to do from the tongue, but he was very apprehensive and he's not allowing me to do nearly EMG from the tongue. So I did from the vastus medialis also, which also showed positive fibrillation. So he had evidence of denervation in upper limb and lower limb. Now the question is now, is it only MND?
What was the maximum amplitude of the motor units? Were they giant ones?
Yeah, Sudhir, I just don't remember. This happened some time back. Only have the recording with me now.
Okay.
I don't remember that. So the MND, or is it MND or MND myasthenia overlap syndrome? No question occurs. He has got myasthenia fatigable, clinical fatigability. Some features are RNS as positive. So is it a combination of MND with myasthenia syndrome? These are ALS myasthenia overlap syndromes. It's a review of 2 cases associated literature. The 25 cases are reported in literature. These patients are divided into 4 groups. 12 patients with myasthenia followed by ALS. 8 patients with ALS followed by myasthenia. 5 ALS patients false positive as an anti-receptor antibody. The other 2 ALS patients were with only myasthenic symptoms. There is also another case report from India, from Kashmir. This is a story of a 56-year-old man who had presence of lingual atrophy, fasciculations, and features of myasthenia gravis. And his myasthenia syndrome responded to treatment also. Some of the motor neuron disease part did not respond. The myasthenic part did respond to treatment. Now, do you think it's an overlap syndrome? If it is an overlap syndrome, we can start treatment for the myasthenic part of the disease. Or is it only a typical MND? This is very crucial in this patient to start the patient on treatment. Will you start or not? Now, we now know that the limb muscles are due to anticonceptive disease because we showed innovation. The only finding which is odd for MND is affection of ocular muscles. We know bulbar can be easily be affected. Now, the crucial point now is the ocular muscle affection. Is it part of the anticonceptive, part of the MND, or due to myasthenia? That's the point to differentiate. Any other bedside test can you do to differentiate the two so that we can go ahead with the treatment of anti-myasthenia gravis treatment, at least for the tail musculature?
Ice pack test, sir.
And that is negative. Fatigue, there's no clinical fatigability. Ice pack was negative.
Dr. Rakesh Singh wants to ask something.
Yeah, please.
Sir, can it be a seronegative musk like
Yeah.
those with LRP myasthenia, which looks like musk, and they would respond to steroids?
Yeah, myasthenia is musk myasthenia is a good possibility, but the point is that after I have demonstrated innervation in the upper and lower limb muscles, till that time
it can be in a musk. One can get acute innervation potentials.
But do you think such a profuse denervation, the upper and lower limb muscles here, with the weakness, with the negative diagnostic mean test, only positive
Yeah.
point, wavering myasthenia in the limb is the clinical fatigability and positive RMS. RMS is well known in my illness also.
True, sir. Yeah.
The involvement of the nuchal muscles also, neck drop and neck weakness favors
Yeah.
myasthenia.
Yeah, that's all that can occur with motor neuron disease, can occur with myasthenia, inflammatory myopathy. That the many things can produce that kind of a pattern, but that they don't differentiate the two. That's the problem.
Dr. Soumya Sundaram wants to ask
Yeah.
if decremental response. Dr. Sundaram?
Soumya?
Yeah, I just wanted to know whether the brainstem lesion can show decremental, mimicking myasthenia gravis, show decremental response with RMS.
Facial muscles?
No. Can you get decremental response in a brainstem lesion?
Brain? No, that part I don't know. But brainstem lesions are well known to produce myasthenic symptom. How did they produce? I mean, it can produce. It can produce. Now you remember that article says it can produce. Not only neospeak and responsibility, decreased RMS also can occur.
Okay, sir. Thank you.
That is why they got confused with myasthenia in those patients.
Okay. Thank you,
The
sir.
first, okay, what bedside test can I do to differentiate whether the ocular muscle is due to myasthenia or part of motor neuron disease? Then I can differentiate whether it's an overlap syndrome or only purely motor neuron disease. You know, one is a very simple bedside test. What test? Oculocephalic reflex. See this, why oculocephalic reflex? You can differentiate whether the extraocular muscle abnormality is supranuclear or intranuclear. If it is positive, if oculocephalic is well present, it cannot be myasthenia, nor myopathy, nor element weakness. It has to be supranuclear. So I did the oculocephalic reflex. It's completely correctable, going up and down. So the vertical restriction was correct by oculocephalic, telling you that the ocular muscle involvement is supranuclear. Now the myasthenia, the strongest point for every myasthenia now get ruled out, that we know it is due to supranuclear. Now is it atypical MND? So the thought came, was it paraneoplastic? So I did CT abdomen was normal. Paraneoplastic antibody profile was also negative. Now, again, still thoughts atypical MND with vertical case palsy. This case was pushed very well. I was working initially. One of the PGs there, Dr. Ansel, picked up an article and told me, sir, this is described in literature. He brought the article to me. This article, he brought the article to me. Atypical motor neuron disease with supranuclear vertical case palsy and slow saccades. There are subsequently many articles are there, slow vertical saccades, motor disease, correlation function. Some kind of frontotemporal dementia with motor neuron disease can have vertical supranuclear palsy-like phenomena with motor neuron disease, just like our patient with a vertical case, which is correctable by oculocephalic. So this case is an atypical motor neuron disease with a vertical case palsy, probably a beginning of a FTD PSP syndrome. FTD motor neuron disease PSP syndrome, we don't know. Only time will tell what the evolution is. So the only point I want to bring up, to bring this point is that in the case of ocular muscle infection, the affection is symmetrical, always to oculocephalic to load case palsy, where one cannot look for wasting or fasciculation in the muscle, nor EMG can we do in the muscle. This is the point. So any questions on this case?
No, Madhu, I have a comment.
Yeah, please.
I mean, it's very interesting as usual. All your cases are very, very learning for us. And I'm sure next week I will see a case similar to yours and I'll remember this case and it always helps. But one of my comments is that when we find any one particular finding, which is suggestive of any particular disease, we must rule it out. Even though it's not a full house, even though other things are atypical. So for instance, in this case, since there were tongue fasciculations, even though other thing is not fitting in MND, and there are these odd things, but the tongue fasciculation itself is such a prominent thing that we have to rule out MND.
Correct, exactly. That is why we got it from the very beginning. I had this possibility in mind.
And if it is not, we can forget about it. At least we can say we have ruled it out.
Yeah.
But see, once you put your, now after that, it may not still be MND. It may be one of those what is called hyperexcitability syndromes and all. But at least we know that it's a generalized anterior horn cell disorder.
Correct. Perfectly right. The only thing is that all our aim is to look for a treatable cause.
Yes,
so
sir. Yes,
even
sir.
the fatigability is seen. I all the time wanted to rule out a treatable condition like muscular myasthenia. Even the fibrillations are seen. But
so how are you treating him, Madhu? Now, how did you treat him?
No, I don't know. I couldn't do anything for the patient. I just gave him symptomatic treatment and sent him. Because now I want.
But you tried oral neostigmine, which you tried in one of your patients previously.
I did not try in this patient because.
Okay, Madhu. Thank you so much. Thank you so much.
Any other questions? If not, I'll go for the next case.
Very nice. Go ahead.
Shall I go to the next case?
Yeah.
Okay, this is a 65-year-old lady who had presented with acute onset of pain in the left side of the neck, which in few minutes spread to all around the lower neck and upper chest at 8 a.m. in the morning. She was taken to the hospital, diagnosed of acute MI, admitted in the cardiac ICU, where the ECG did not show any cross finding, but subtle, some variations that is told. And she was observed in the ICU with the diagnosis of acute MI.
What was she doing when this pain started?
So that I do not remember now.
Okay.
She developed, that's all I remember. What she was doing, I forgot. While in the ICU, while she was going to the toilet, she noticed weakness of her left lower. There is no numbness. She is not a non-diabetic. So this is the examination the first day. The video I'm going.
Wait, Madhu.
Yeah, please.
Why don't we ask people to start thinking about possibilities now itself? What could this be? So anybody wants to give their a shot at what are the possibilities when somebody is having this sort of symptom? You can raise your hands and I'll unmute you. Okay, 1 minute. Dr. Seema wants to. You can unmute.
So that's the best way. You can moderate from your side.
Yes.
That's the best thing.
Dr. Seema?
Yes, sir. Good morning, sir.
Go ahead.
Sir, vertebral artery dissection, if there was a history of neck manipulation, and sometimes even if it's not there in elderlies.
Correct.
Yes. Dr. Savali also wants to say something.
So cervical cord lesion or aortic dissection.
Yeah, that's a fantastic diagnosis. Okay, good, very good. So I'll go to the findings now. This is the examination on the first day. So unfortunately, I could not take the video on the first day because he was in the ICU. I was not prepared for that. So examine came. The video was taken the second day, but the findings are seen the second day. So first day, the canals are normal. Motor system, upper limbs. There was grade 5 power of the deltoid and biceps. Grade 3 power of both triceps, wrist and finger flexors, and extensors of the small muscles of the hand. Grade 3 power of triceps, wrist and finger flexors and extensors, and small muscles of both hands. The lower limb, grade 1 power of the left lower limb, both proximally and distally. In the right lower limb, proximal muscles are weak, grade 3 to 3, 4, 3 to 3 plus in the proximal muscles right lower limb, but grade 5 in the distal muscles right lower limb. Now DTR, biceps supinated normal, triceps superficial absent, knee jerk were absent, absent angle jerk, plantar indefinite. That means all reflexes are absent. except the biceps and supinate. Sensations are all normal except for impaired vibration and joints and over both feet. That also I'm not very convincing. She said is impaired. That, but pain, temperature, everything was normal, and abnormal sensation in the upper limb.
Again, let me. Yeah. Okay. Yeah. You're asking. Good.
No, you can ask. So
The same thing I wanted to say. Now, what are people thinking?
With this finding, what are the possibilities?
Dr. Seema, Dr. Savli, anybody else? Soumya? Anybody else wants to speak? Raise your hand.
So still cord.
Pardon?
Still cord.
Rakesh, you can speak. You can unmute yourself. Okay, so
sir, bowel and bladder are involved, sir.
No. One bladder not involved.
How do you explain the absent reflexes? Who said cord just now?
Me, Sabli.
Yeah. So definitely cord is possible, but how do you explain the absent reflexes?
And the proximal muscles are more involved in the lower limb.
Yeah.
Right lower limb, 8.
It is definitely possible. It is an acute lesion, so it could be something like a spinal shock, and that's why the reflexes could be absent. Obviously, this is not a GBS or it's not a neuropathy or something like that. So it has to be cord. But the cord level seems to be below C5-6, so C7 downwards, because the bicep deltoid seems to be spread.
Yeah.
Planters, sir? Planters?
Planters are flexor, indefinite.
Flexor, okay.
Yeah. The problem to attribute absent reflex to spinal shock is a problem. By spinal shock, by definition, is all should be absent. Motor weakness should be there, loss of sensation, and reflex should be absent. But here is power is about distal muscle is about 5 in the right lower. That reflex is also absent. Angle jack is also absent. So the upper limbs also proximal muscles are no. Anyway, you can call it level at that level. Even the right left lower limbs also got power about 3+. So I think I will go to the these are the possibility. Acute cervical myelopathy could be GBS in this patient because he had impaired vibration distally in the lower limb, absent reflexes, and he has got proximal muscle weakness more than the lower limb.
Why the neck pain?
Yeah, that's the odd point. That's exactly right. So the problem comes, and you see the patient is in GBS or is acute myelopathy. So something which you can't explain. So what is the point where GBS is proximal lower limb with absent reflexes, distal muscle sensory loss, and the feet. But as Deer said, I also considered acute cervical myelopathy as the first possibility. So I start examining second day. This examination finding on the second day, the deltoid normal is told again, biceps also normal. Biceps is weak. Motor findings remains almost the same. Basically, and gives a weak. Almost weak. That is 3 plus power. 3. Exercise I could overcome that. That is about grossly weak, about 2 power of left. But distal muscles are more powerful. And the proximal muscle. That is grade 5 on the good side. The reflexes, bicep, supinator, normal just like before. And the triceps, which is absent on the first day, became acceptable now. Still acceptable.
Oh, that's come up.
It's absent at 1 day before. Finger pressure also came back. Knee jerk was absent yesterday, maybe 1 day before, became acceptable now.
When I saw it today, everybody is absent. Something is absent there.
And angle jerk continued to be absent. With good power of the distal muscles, angle jerk continued to be absent. Plantar became sensor on the third day. This time with the syndepilate, slightly tendency to go up. Again, it is independent on the second day. Now, second day findings, same motor system pressure weakness is same as the first day. That is grade 3 power of triceps, finger flexion weakness, and small muscles. Lower limb remained the same. Grade 1 power of the left lower limb, both proximal and distal. Grade 3 to 3 plus the proximal muscles, 5 distal muscles. The triceps and finger flexion reflex became elicitable on the second day, which are absent on the first day. Knee jerk were normal bilaterally, which are absent on the first day. Both angle jerk continued to be absent, plantar indefinite. Sensation remains the same. Except the third day, can say the finding again. The angle jerk has now started appearing.
Sorry, there was no bronze required, no pinprick temperature loss.
No pain loss anywhere. Both sides.
Angle jerk
became acceptable now. Plantar, left plantar became excellent. So plantar became sensible. So what do you think now? What investigations you would like to do now?
Localization is the cord, so first possibility. Then MRI of the whole spine is the second investigation. Sir.
Cervical spine MRI.
Cervical spine MRI. And with what diagnostic possibility do you have in mind?
Either vascular or even maybe with the neck pain and epidural hematoma or something like that.
Okay. But started improving without any intervention. So as you said correctly, most likely ischemia should be the first possibility. So the MRI was done, which showed a long extensive hyperintensity in the anterior console region from the cervical down to the thoracic here. And show the horizontal axial cut. Hyperintensity was seen in the anterior console bilaterally. It's extending down, see D1, D2, D2 to D3 again, they call snake eye appearance.
Yeah.
And the CSF is also normal. So what is the diagnosis now?
Ischemia.
Antispinal artery occlusion. My question now is not that it's not the point why I brought the case. I did a CT angiogram, the thoracic aorta was also normal. I couldn't find any dissection. So this is after 3 months, she became perfectly normal. Okay. Now the questions to ponder: one, why the proximal muscles are more affected in lower limb in pyramidal lesion? Second, why the DTR were absent in the upper and lower limbs initially with retained power and normal sensation causing confusion with the GBS? That is the 2 questions. The point is that in ischemic myelopathy or even intermediary lesions, the lower limb proximal muscles may be predominantly affected even in pyramidal lesion because depending upon which part of the pyramidal tract is affected. If you know the antispinal artery supplies the cord through sulcocommissural artery, which either turn to right side or left side and supply the medial part of the pyramidal tract. The peripheral part is supplied by the subcutaneous arteriosus, which is supplied mainly by the arterial circle, contributed by the radicular artery. So antispinal artery occlusion may affect only the medial part of the pyramidal tract predominantly, causing the proximal muscles to be affected more than the distal muscles. The distal muscles are more peripherally situated. That is why many times you get a whiplash injury to the cord, you may get only upper limb pyramidal signs, your proximal muscle, but distal muscles may be normal. Second, why the DTR were absent in upper and lower limbs initially with retained power cannot be explained by any spinal shock or pyramidal lesion. You have to have an element finding. And that is because in antispinal artery occlusion, there is long extensive ischemia of the anterior console, which is most vulnerable because antispinal artery is descending down, supplying many segments. And even though many segments are supplied, the culprit or the affected region only in the anterior console, which requires more oxygen supply and get transiently dysfunctional in ASA. So this is described only in antispinal artery occlusions. Like you can find occlusion may be at level C3, C4, but you can have extensive element which recover also. If you go back to the literature and see ASA occlusion, all of them have picked up this finding. So paradoxically, pyramidal affection can produce more weakness of proximal muscles than in distal muscles due to the more affection of the medial part of the pyramidal tract. Now this is I think I'll show just one point. I'll show the picture. I don't know where I get that. Okay, in fact,
Madhu?
Yeah, okay. I wanted to show the picture of that. Somehow or other is not seen here. Anyway, it doesn't matter. Okay. Yeah, tell me. Yeah, the case is over. Any questions?
Yeah, Madhu, I have seen one patient, similar patient, but he also had a dissection. But here, so this means that you can have this vascular thing even without dissection directly.
Exactly. It is only mild affection is improved.
My question is that if I heard you right, there was a involvement of vibrations in the beginning of the presentation.
Yeah, he had vibration in the lower limb.
Now, how do we explain that? Is it because of edema or something? If it is an anterior spinal artery?
That difficult to explain. The thing is that, in fact, I wanted to show the diagram I missed it. The supply of the spinal cord, what the supply is by anterior and posterior spinal artery, which is replenished by the radicular arteries. So depending upon which artery is affected, which segment is affected first, you can have complete even posterior column sensory loss in ischemic myelopathy if it is not the antispinal artery, if the radicular artery is affected. So in the case of aortic dissection and all, it is not necessarily be the antispinal artery which compromised. The radicular supply, the radicular artery may be affected, which goes to the intervertebral foramen, which replenishes the arteriosus. So you can have various combinations of sensory loss in ischemic myelopathy.
But in this case, it was we have shown radiologically, no, it was only anterior spinal artery.
Yes,
yeah.
And Madhu, it's also a little difficult to explain why posterior column was affected and spinothalamic spared.
Right, that is exactly correct. In ASA occlusion, that should not occur. But this patient had ASA occlusion, that posterior column loss cannot be explained by ASA occlusion, as you correctly said. There should be some ischemia in the PCP and posterior spinal artery, probably because the radicular artery, which is supplying the circulus artery, is also getting affected. In thoracic aortic dissection and all, what happens is that it is not ASA which is affected. It is the radicular artery which replenishes the ASA or the circulus artery which is affected. So depending upon which area is vulnerable, that may be the only explanation. But it is described in literature that in radicular artery occlusion, you can have posterior column involvement as well. Unlike a pure ASA occlusion.
Sir, for such a long extent involvement of the dorsal cord, the spinothalamic is relatively spread in both sides, so it can occur.
No, dorsal cord need not be extensively longly affected. It may be one portion of the dorsal column may be affected at a particular level where the ischemia has occurred. Here, the ischemia has occurred at the level of C6, C5, C6 or C7 area, where the motor weakness is normal at the C5, C6 segments. The weakness is only from C7 downward. So the level of affection is at C7. That is the area where the ischemia has occurred. But the antecondylar dysfunction can extend downward You may not find hyperintensity in the other areas in the long extents, just like our LETM. No. Here only the anticonceptive will show the anti-hyperintensity. The so-called snake eye appearance only will extend down, not the whole hyperintensity will not extend down. Unless it's a dural AV fistula, something like that, where you can have a ischemic edema occurring secondary to that.
Madhu, this patient had upgoing plantars, which suggests pyramidal involvement.
Yeah,
but he also had element signs in his lower limbs?
Element finding was there in the upper and lower limb initially, the form of absent reflexes.
So, yeah.
That is described due to the anticold ischemia, preferential affection of the anterior cells.
But he didn't have wasting or fasciculation
No, because an acute lesion, it can only affect the reflexes first.
Yeah.
Wasting can only come later on. They don't recover fast. It's a
Sir, weakness of, sorry, sir. Sir, weakness of the thighs is the element type or UMN type? So what you say about the weakness of the thigh muscle, sir?
No, weakness of the thigh is UMN type. Why UMN type? Reflex become elicitable, became in the next day became elicitable. It's a transient dysfunction due to the reflex loss, due to the anticonceptual dysfunction. Not a persistent involvement of the anterior console.
Yes, it depends on exactly what is the vascular distribution of the ischemia. That can cause all these permutations coming. And that's a great case, great learning, Madhu, as usual. Thank you.
Very nice.
Yeah. Any other questions? I can go to the third case. Third case is a little more interesting. Interesting in the sense that thought-provoking. Shall I go to the third case?
Yes, sir.
Yeah. This is a 65-year-old diabetic man who has come with history of low backache with radiation along the right thigh for 3 months. This was followed by difficulty in walking.
Just 1 second. Dr. Patil has asked, how was she treated because she improved so well? Apart from antiplatelets and statin, did you give anything?
Nothing. I did only put down antiplatelet drugs. I did not do anything. She spontaneously improved. She became perfectly normal. Because ischemia is only very mild. That is why she's become improved so dramatically. Most of the cases which I have seen, they also improved. I don't know what literature says some of them became epileptic and you do lumbar puncture to relieve the pressure and all. But most of them, unless some of the cases, old people who had this the aortic dissection, they have not improved. But this kind of a upper part affection, they improve most of the time.
No, no, Madhu, I would make a comment. I have also seen some of the patients recovering extremely well, even with dissection. But I have seen some these anterior spinal in the setting of these interventional procedures.
Exactly.
Following interventional, that bronchial artery catheterization, they have not done well. They have then continued to be. So
Correct.
Some of them may not do that at all.
Correct. Perfectly right. Perfectly right. So this is a 65-year-old diabetic man has come with history of low backache with radiating pain along the right thigh for the 3 months. This was followed by difficulty in walking in the form of buckling of the left knee. That is what he said. No paresthesia or bladder problems. No root pain. I am showing the history of the patient. I just want to take only 1 minute, less than 1 minute, to show that how he describes the pain. Because I was hard to believe his history, so I thought I'll show the history part also to you. Is the pain showing on the right and buckling of the left knee. That's all the point I want to tell. So he had pain in the right thigh and back and buckling in the left knee. So this examination finding.
Wait. Let people talk. From this history, does anybody want to say anything? What could it be? No one's raising hands. So I mean, would you expect the knee jerk on the right side to be present or absent? Maybe a L3-4 radiculopathy disc prolapse seems the first possibility, and so maybe the knee jerk should be absent. But let us see what we find.
Okay. Now I'll go to the findings of the patient. Findings were. This is examination finding. It's got upper limb power normal. Deltoids are normal. Biceps normal. Triceps normal. Hand grips were normal.
Even your biceps, triceps seem to be normal.
All muscles were normal.
പിടി പിടിച്ച് അകത്തി പിടി കേട്ടോ
The lower limb.
പൊക്കി പൊക്കി പിടിക്കേ മാക്സിമം മതി വിട്ടോ ഇത് പൊക്കിക്കേ
normal.
പൊക്ക് പൊക്ക് ആ മതി ഈ മുട്ട് മടക്കിക്കേ
Might
ചവിട്ടി
be weak
നൂർത്തേ
on the left side.
ചവിട്ടി മാറ്റല്ലേ
But might weak.
ഇതും ചവിട്ടി മാറ്റ്
Significant weakness in left
ചവിട്ടി മാറ്റ്
quadrant. He could not extend the left knee.
ഇനി കാലകത്തി പിടിച്ചേ അകന്നിരിക്കണം പഠിപ്പിക്കാൻ സമ്മതിക്കരുതേ ഇത് അകത്തി പിടിച്ച് അതല്ല കീഴോട്ട് തള്ളു ആ ഇതും തള്ളു 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 തള്ളു
That is slightly weak on the left side.
ഇത് വടി പോലെ പിടിക്കുക സ്ട്രൈറ്റ് ആയിട്ട് ഈ പാദം മുകളിലോട്ട് എടുത്ത് അങ്ങനെ ഇരിക്കണം ഇതോട്ട് തള്ളാൻ സമ്മതിക്കില്ല
Right, go to the gate by power.
തള്ളോട്ട് പൊക്കിക്കേ
Left eye could easily overcome.
പൊക്കിക്കേ
AHL is weak on the left side. Right side 90.
ചവിട്ടിക്ക് എന്റെ കയ്യിൽ ആഞ്ഞ് ചവിട്ട് 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 മതി
Reflexes. Biceps normal. Supinator normal. Triceps absent bilaterally.
ചെല്ലി മടക്കിക്കേ
Finger pressure is also absent.
മടക്കിക്കേ
Abdominal pressure is normal, all four quadrants.
ഇനി ഇരിക്കട്ടെ.
Knee jack, right knee jack was just telescopic absent. Left was quite telescopic, very well telescopic, or can call it in English. Either right is decreased or left is increased. Hand jacks were absent. He is a diabetic.
Diabetic ഒന്നുമില്ലല്ലോ അമ്മ.
Diabetic. Landa, right was maybe extensive, but left was definitely extensive.
കാല് വലിക്കരുതേ.
No doubt about the left extension.
ഇതും ഒരേപോലെ അറിയാവോ? അറിയാലോ?
Primary models were all normal.
ഇതോ ഇതോ
normal.
ഇത്
Vibrates is also not impaired distally over both feet and ankles.
ഇപ്പോഴോ ഇപ്പോഴേ ഉണ്ട് ഇപ്പോഴേ
There he is able to feel over the knee.
കണ്ണടച്ച്
Thrombus mildly positive. Look at the gait. He has got a quadriceps gait on the hand. Before that, he could get up in sitting position with mild support. Look at the gait. He has no spasticity, but his buckles on the hyperactions the knee on the left side. He's got a quadriceps gait on the left side.
നാളെ തിരിച്ചു വന്നു വെച്ചാൽ നാളെ തിരിച്ചു വാ.
Left knee goes in the left direction. Okay, you want to see the gait once again, or I can go to the finding? Okay. Now examination, motor system, upper limb tone power normal, lower limb mild wasting of both thighs, left more than the right. Power hip flexion normal bilaterally, hip extension normal. Grade 4 plus power of both hip abductors and adductors. Mild grade 4 power on the left quadriceps, right quadriceps almost normal. Right dorsiflexus, EHL plantar flexus normal on the right side. Left dorsiflexus grade 4 plus, left EHL is. So here you find there is weakness, definite weakness at left quadriceps and left dorsiflexus and EHL. Very mild weakness of the right quadriceps. Other muscles remain plus minus. DTR upper limbs, biceps supinated normal. Both triceps finger flexion absent. Come to the lower limbs, left knee jerk was brisk, right knee jerk absent. Both angle jerks absent. Abdominal reflex present in all four quadrants. Plantar left upgoing, right indefinite. Sensations normal in the upper limb. Impaired vibration positions for both feet. Quadriceps gait, left knee goes in the right direction while walking. Thrombus mildly possible. If you want any clarification of signs, I can show once again.
So just 1 minute. Left. Let's see the power. Which leg is weaker? Left leg is weaker.
Left is weaker.
Okay. Okay. And the left knee jerk is brisk. So it is
left knee jerk is brisk. Left plantar is upgoing. Right knee and both angle jerks are absent. Angle jerk could be absent because it's a diagonal.
Somebody is raising the hand. 1 minute.
Yeah, please. Yeah.
Dr. Ajit Mohan. Yeah.
Ajit, you can unmute yourself, Ajit.
Ajit, unmute yourself. Anybody else wants to speak till then?
Yes, sir.
Yeah, please.
So there are definite pyramidal signs in the lower limbs, plantar limb extensor.
Yeah.
And there is a lower motor neuron sign at the level of L3, more on the left side because of buckling. So it is localizing to epiconus area.
Yeah, perfectly right. Yeah, perfectly right. Because the only thing is the lesion has to be above L3 because the left knee
is brisker. Yeah.
But in that case, the weakness can be due to that segment involvement. That's a good possibility of activity. But the only odd point, he came with the pain in the right thigh. And right knee jerk is decreased. It's not a simple case, a tricky case.
Dr. Dasari wants to speak.
Yeah.
So, with grade 4 power in the left quadriceps, can it explain the buckling, sir?
I didn't hear. There is weakness in the left quadriceps. What did you ask?
It's a 4/5, sir. Can it cause buckling, such a significant buckling of the left knee, sir, with the grade 4 power?
In fact, actually, even though he said buckling, what is happening is that knee goes into hyperextension. He said it's buckling. Probably some unsteadiness or that. Yeah, that's why you said.
Could be everything be diabetic related, sir. In the presence of severe pain in the right lower limb with low motor signs in the lower limb, except for the plantar going in the left lower limb, so everything looks more of a diabetic related radicular neuropathy.
Good for diabetes.
No, if it is a diabetic flexor neuropathy, that reflex on the left side should be decreased compared to the right side. Because his weakness and wasting was more on the left side.
And how
why that reflex is becoming?
His gait also. His gait is out of proportion to the weakness. So obviously it is not a lower motor neuron problem. It has to be upper motor neuron. The gait is, his power is grade 4 plus or so, and yet he's hardly able to, he's buckling and he's unsteady while walking. So plus of course the plantars and everything. So it's a UMN lesion. Question is it localization where in the dorsal spine? Is it the mid dorsal or is it lower down somewhere because of the right leg weakness at the onset?
But Sudhir, I perfectly agree with the left elbow lesion that is present in the left lower limb. The point is that such patient usually will not have hyperextension of the knee. If it is hyperextension, quadriceps should be out of proportionally weak. Because in pyramidal lesion, the quadriceps, the last muscle to become weak. Here it has become weak, that is equal to hyperextension. That makes you think that there may be in addition a predominant weakness of the quadriceps either due to element or some other element. That not a typical human is not there because there is no spasticity in the quadriceps, which you expect a lesion above L2. That's an odd point, but or let's say it's a tricky case here. But You saw the finding. So you see the gate, he is hyperextension. That knee jack is brisk compared to the right, and his complaint was pain on the right side. Okay, shall go for the investigation. So epiconus lesion was considered as the doctor was telling, but I thought lesion little higher up. That is my first possibility. I kept his epiconus, but I was not at all happy because his right knee jack was absent. So, and moreover, he complained of pain in the back of the right, from the back of the right thigh, even though buckling was on the left side. So, what investigation was required? So, when initially took a lumbar spine, it showed a disc at L4, L5, which you can see here. But the least above, the D1, L1 normal, L2, L3, 4 normal, where we expect the lesion to be there, caudate and apart normal. Then it's got a bilateral root canal stenosis at L4, L5, slightly more on the right side, and L5 is normal. So it's got L4, L5 IVDP with bilateral marked canal stenosis. Now, obviously, that cannot explain the patient's our finding in this patient. Now, next thing, what could be cortical lesion produced in the left lower limb?
The rest of the cord was all right.
No, you wanted to roll it like a epiconus lesion. Agree.
No,
But before,
cord, even upper dorsal, cervical, query.
yeah, I'll come to that. I'll come to that. So, the cortical lesion was considered because in epiconus lesion, the lesion has to be above, here to put it, knee jack is brisk. That means something has to be occurring above that. So it has to be at least L1, L2. That has to be confused with the cortical abscess. But I agree, again, the hyperextension is very odd for any pyramidal lesion. But this also, since the lumbar spine was normal up to that level, so we thought we'd go ahead with the MRI brain. MRI brain showed bilateral cortical atrophy, multiple lacunar infarcts of the both thalamic and the right corona radiate. And severe degree of atrophy bilateral.
But these infarcts were old?
These are all old infarct, old. This duration was little old. This patient's complaint was 3 months. So can you explain by the infarct in this patient?
Can't explain why left leg became weak and the right leg had pain and numbness with
Exactly, you're right. So this is the way you have to think out of the box. Just finding out one finding in the MRI should not think away from your explanation. So we are not confident at that point. There is no spot. These are taken to explain the pain. I thought was part of diabetic amyotrophy and things like that can be explained by that. But his pyramidal signs, reject, risk, is undoubted, and his findings was weaknesses on the left side. So that we have to explain how that has produced. So I was chasing to find out the cause of the pyramidal lesion. So I took him the thoracic spine, I'm sorry, lumbar spine, that is normal. So one thing was a cortical. Usually, it's not the usual epiconus lesion. Epiconus lesion, you expect an Egypt to be diminished, or that is not there.
Dr. Lakshmi, GSR Lakshmi wants to speak.
Yeah, please. Lakshmi, you unmute yourself. Lakshmi? Yeah, please.
Law, which can produce combination of human and element science.
Perfectly right. Human element
Dural AV fistula.
Okay, that's a possibility we have to keep in mind in the lumbar region. That's a possibility, but still the odd point is that he had pain in the right thigh and femoral signs, and we agreed with you. Maybe a typical presentations can occur. That possibility has to be kept in mind. But the lumbar segment, we did not find AV fistula. We'll go to the upper part, I will show you the feelings. So this is the thing. So it took an MRI brain. So this was difficult to explain the absence of spasticity in the left lower limb, and explain the right thigh pain action angle jack was also difficult to explain. So we wanted thoracic MRI. We all wanted to do it an epiconus lesion. The thoracic MRI was also not. There was no lesion in the thoracic column, and there is no AV fistula in the lower thoracic region.
Cervical is showing some lesion, sir.
You want to see a cervical spine? Is
Yes,
abdominal
sir.
fissure all absent?
So how do we explain the absent triceps, sir? Bilateral
Yeah,
triceps is absent, no,
yeah.
sir?
No,
So could it be cervical myelopathy with superimposed lumbar canal stenosis leading to UMN findings also, and then LMN in the lower limbs?
yeah, that's a possibility. Need not be lumbar canal, maybe diabetic amyotrophy as well.
Yes, sir.
So you want
Yeah,
to
this
think
cut
is
is
that, but remember, he has got no complaints in the upper limb. He's got good abdominal reflex. A symptomatic reflex loss in the upper limb can occur in even evolved individual because of the symptomatic cervical radical reflex. But that's a good thinking, which I have got a point. Okay, so you want
this scan is
cervical.
showing in the involving in the upper cervical. So this scan is showing some the disc bulge in the upper cervical level, lower cervical level.
Lower cervical level you want it because, but
This
the
scan
abdominal
is also showing.
yeah, because hand muscles have good power, abdominal reflex are very elicitable. Okay, so but I'll show you the cervical spine. This is cervical spine, sorry, thoracic spine axial cut.
So,
And
did he have a reflex present in the wasted muscle?
the left knee jerk was wasted partially, and that knee jerk was brisk. Right?
So doesn't that suggest the motor neuron disease kind of a picture?
Yeah, that could be, but the problem is that he came with the pain and radiating pain in the right lower limb and buckling in the left knee.
Which we
Possible,
can't.
yeah,
Yeah,
possible. Upper limbs were not affected, only lower limbs confined to
only
that.
lower limbs were affected.
So this is cervical spine. Showed hyperintensity in the cervical cord. You said made at the level of C5, C3, C4, C5, CC, CC7. I'll show the axial cut. It's a C3, C4. C4 shows an intramedullary hyperdense lesion in the cord on the left side. Here. It will more lateral part of the pyramidal tract. So what is the diagnosis now? How will you synthesize everything in this patient?
Could you do a contrast MRI? Sometimes spondylotic myelopathy may show contrast enhancement there.
But here the lesion was, no, there's no compression of the cord. It's intramedullary hyperdense lesion. Very clearly you can see that. See, this cord out periphery can be seen here. This inside is hyperdense. So actually this all.
Can we see the sagittal image again?
It's strictly unilateral, isn't it?
Strictly unilateral.
Vascular pathology, so involvement.
It's like a half cord. Yeah, that's exactly.
Exactly.
Yeah.
What is it? Is correct.
Half cord
So,
is exactly.
So it's actually an ischemic myelopathy. Just I discussed the last case affecting the cord. Spondylotic myelopathy can produce predominantly ischemia. This radicular loss may or may not be significant. That only shows that underlying spondylotic lesion is there. But the cord involvement is ischemia, affecting only the central part, which may only be confined to one part of the cord if the ischemia happen to be more in the territory of sulcocommissural artery, as in this patient. And why the question now comes, I'll come back to the question. So this is the one, what is the cause of the pain in the right thigh? Most likely diabetic amyotrophy. That's subsided with the treatment. And spondylotic ischemic myelopathy. And ischemia is the lateral part of the pyramidal tract. Now, question now, why there is no spasticity in this patient? The problem is that you get spasticity in pyramidal tract. The pyramidal tract contains many fibers, corticospinal fibers, which mediate the power of the muscle. There's a cortico-reticulospinal tract, which is responsible for the maintenance of the tone, which inhibits anti-gravity, which maintains anti-gravity muscle tone, the lesion of which will cause spasticity, and the other long loop reflexes, which results in loss of abdominal reflex, and the loss of FRA, inhibition of the FRA responsible for the upgoing time. So all these are in the pyramidal tract. It all depends upon which fibers are affected by ischemia or demyelination, which results in whether spasticity is present or not. Unlike a compression of the cord will affect the whole pyramidal tract. It will not respect which fibers the pyramidal tries to be involved. It compresses all the fibers, causing the classical pyramidal syndrome with weakness, spasticity, brisk reflexes, subgain plantar, absent abdomen. But in the case of intrinsic lesions affecting a patchy involvement or selectivity involvement, may affect only some weakness or may not affect, may not produce spasticity. So this is the only explanation I can. I do not know that my explanation is correct or wrong, but this is the only way I can explain why in this patient there was hyperaction, there was no spasticity. Instead, there was more weakness can produce hyperaction. You can have more weakness in the proximal muscles in lesions in the pyramidal tract due to ischemia, as told before, if the middle part is affected first. So that is explanation. I'll show the picture here. In ischemia, if you go to the literature, they say that proximal lower extremity weakness and stiffness may be the earliest symptom, followed by dorsal column, sensory loss, and spastic gait. Ischemic spondylotic myelopathy. In this patient, cause is more often acute. Now, this is the blood supply here. So this is the sulcocommissural artery supplying the middle part of the pyramid. This is the middle part of the pyramidal tract. Lateral part is where the vasa corona. The lesion is this is the pyramidal tract. The upper limb fibers are more medial. If the ischemia happens here, it will going to affect upper limb. Trunk, only lower distal part is most peripherally, which may be contributed supplied by the sulcocommissural. It all depends upon which part is affected. And here it is again the picture showing that sulcocommissural artery turning to one side again, producing only half cord involvement. Now, why this the fibers carrying the tone or the corticospinal tract are not exactly the corticospinal tract. They are situated outside or close to the pyramidal tract. See, this is the area where the fibers for the 2A is the spinal tract. This is the classical site of the reticulospinal. This lesion of which cause spasticity depend upon whether these fibers are affected or not to cause the spasticity. So that is why in certain intramural lesion spinal cord, it will not produce the classical spastic syndrome as you see in extramural. Okay. Any questions on this case?
So the pain in the right lower limb, back of the thigh, and also the absent right knee jerk, sir.
Yeah, but this part of diabetic amyotrophy he had.
And sir, the buckling of the left leg, sir.
Yeah.
Left knee.
That's due to the weakness of the quadriceps. He had weakness of the distal muscle as well as quadriceps. Quadriceps are more weak, slightly more weak probably because the ischemia is affecting the most of the middle part of the pyramidal tract, because that's a site supplying the proximal muscles.
Then the preserved abdominal reflexes, sir.
Yeah, yeah, because if the lesion, even the cervical lesion is there, it's only the lateral part of the pyramidal tract is affected. That is, the upper limbs are not affected. The lesion is not, upper limb hands muscles are not at all affected, because the middle part is paired. It's only the selective part of the pyramidal tract. This is thinking only after seeing me. I did not make a diagnosis straight away. I thought of an epiconus lesion. That's my first possibility I kept in mind. But since it's not tallying, and then going step by step, I went and do the MRI of the cervical spine, because the absent reflexes, that's why I thought. This explanation all subsequently after seeing my I did not think of finishing. Any questions in that case?
So the lumbar disc bulge, it should be ignored or should be treated. So in this case?
No, not totally ignored, because it's totally unrelated to many people. You take the MRI, you can such canals, asymptomatic, ignore them. It's not causative of anything for this patient.
Sir, the moment we see a buckling of the knee, we always think of a lower motor neuron. The thinking goes always towards the L3 lower motor neuron.
No,
that is what this case is. Yeah.
No, that's applicable here. But buckling only indicates corticeps weakness. Even in human lesion, it's got a corticeps significantly weak, you get buckling. Only thing that classical pyramidal lesion, by the time buckling occurs, the distal muscle should have been affected more than the corticeps. So that's the pattern of pyramidal weakness is first eflexor, then dorsiflexors and everter. These are the first two muscles affected. Corticeps, the last one get involved. That is why in pyramidal lesion, Buckling is not. Not that it cannot occur. It can occur late when the cortex become weak.
Yes, yes, perfect.
Okay. Yes, sir.
Madhu, when we are saying ischemic spondylotic, how is it causing ischemia? Because there's no compression. So why only on one side? And how will you treat it? Dr. Harshita wants to ask you, how are you going to treat this ischemia?
No, there's no treatment for us. Only give antiplatelet, like nothing can be done. Because if you, I wanted to some more pictures to you. Just 1 minute, I can maybe able to find something here. Yeah, look at this picture. This is the how the blood supply reaches spinal cord. This is the antispinal artery, which supply through this antispinal artery supply only the anterior to the middle part. The rest of the cord is supplied by this vasa corona here. This vasa corona is only it's replenished at every segment by the so-called radicular arteries. These are the radicular artery coming from here, entering the spinal cord, replenishes the posterior spinal artery, replenishes the anterospinal artery through these radicular lines. This is where the compromise occurs. There are 3 levels where there is a large, this I can see here. This is one of the important radicular artery here. 2, 3 may be there. Another important is at the D7 level. That is why we call generally the watershed zone is the D4 because the artery coming from above and below meet here, supply become less and less. And the major one is the radicular artery magna.
No, but I'm not so sure how one unilateral cord lesion can be caused by ischemia. Because,
because this antispinal artery is supplied, replenished by the radicular artery. So if this artery is compromised by the decreased blood supply to that area, that can get affected.
But the anterior spinal artery is in the midline. So even if one side radicular artery is affected, the ischemia should happen in the anterior spinal territory, which is midline.
Yeah, what you said is perfectly right. They're difficult to explain. But as told before, the picture may not strictly fit in with what do you call fit in with the vascular territory, as in cerebral circulation. For example, in the case of in the nucleus corpus embolism, this can go straight away to one artery and put it's only half cord syndrome. Something similarly, this ischemia may be more vulnerable in one area. That's all I can say. I perfectly agree with you. I cannot explain an answer to your question exactly why it's on one side. It's the only thing which I can think about it. Moreover, probably the peripheral part is affected here. It's a vasa. This vasa corona is supplying the peripheral part of the cord. That may be affected here. That is why this ischemia is affecting that part.
Hello, sir.
Yeah. Any questions?
Sir, thank you. Jibu here, sir. Jibu.
Yeah, tell me, Jibu. Any comments or questions?
Sir, is there any role of DSA, digital subtraction angiography, to actually ascertain our findings? And hello, sir.
That's very good. You can't pick up in DSA because these small arteries are very difficult to pick up in DSA. If you are a AV fistulas are not very easy to pick up.
Okay, I was just looking up, Madhu, but we'll need a little explanation. I was just looking up again. Anterior spinal artery usually is bilateral. Posterior spinal artery can be unilateral, but posterior spinal will be mainly posterior column, and it will not affect the region that we are seeing. So I don't know whether this was some unusual demyelination or something else, because it is not fitting in an arterial territory.
No, I think so this can occur with the arterial involvement because the sulcocameral artery supplies only one half of the cord. The antispinal supply both sides of the cord because from the anterior spinal, the sulcocameral artery arises here and goes only to one side. The other sulcocameral artery goes to the other side, opposite side. So if this is affected, ischemia preferentially occurring in that area, then only affect the half of the cord. That is well described in ischemic myelopathy.
Okay.
But here your question is valid because why a radicular artery here is causing central part here? This may be probably already compromised. The brunt of attack becomes more manifest there. Just like in cerebral circulation, if one artery is affected partially, the more proximal occlusion will produce the brunt of affection in that area which is already compromised.
It's strictly unilateral. There's nothing on the other side, and it's quite bad on one side. So it's not more on one and less on the other. It's only on one side. So it's a little.
That can I'll show you another case next week where the nucleus pulpus embolism can put only one half of the cord.
I think in case of these spinal cord ischemic syndromes, there is not as extensive work done as in the case of brain vascular syndrome.
Yeah, correct.
So if this thing would have happened in brain, we would not have asked any question, because you can have a lacune, you can have a mega lacune, you can have in one that. But in ischemic myelopathy, we have got that that stereotypic anterior spinal artery, which we consider that it should be bilateral and all. But it is if we take the brain model here also, then any branch or any artery can be affected anytime. It's just that we don't know. And now I want to know, Madhu, what was according to you, or do we have any clue what was the cause of ischemia, the underlying mechanism, which we all the time tell in brain, there is the underlying atrial fibrillation or underlying lacunar or underlying any other atherosclerosis. Here, do we have any mechanism of, vascular disease has to happen against the background of something, vasculitis or something, but many times it may be unknown. So in this case, do we have any underlying cause other than his age, I think?
Yeah, so what I'll tell you, in most of the so-called cerebral spontaneous myelopathy, nearly 30 to 40% actually due to ischemia. If you read, I can send the literature to you, because most of them are due to the root canal stenosis where the radicular artery is compromised. That often we miss it. That is why the people who do not respond to spontaneous myelopathy treatment is because the ischemia is the culprit causing the cord damage, not the compression. The compression may be very mild, but ischemia is the one causing the hyperintensity within the cord. That can affect confine only to one half of the cord. I can send the literature, no problem, because it's well amply described in the spontaneous myelopathy ischemic cord syndromes. Very well described. Because of the artery is going through the canal, and the canal is compromised by the stenosis, by the spondylotic changes. That is, it's a very well described in some spondylotic myelopathy.
But this is a little controversial, because if we really say, as somebody has asked, I don't know, that if we are saying spondylosis is the cause of the ischemia, that means there is some compression causing the ischemia, then one should relieve it and not just give antiplatelets. So this is controversial, whether the spondylosis is actually causing it. Hypothesis maybe, but I don't know whether everybody will agree on this. We can leave it as
correct. It may not be correct, but what I have read in literature is the canal stenosis, root canal stenosis, through which the radicular artery enters the spinal cord, get compromised. It will be difficult to relieve that compression. Anyway, I'll in next presentation, I'll support literature. I can show you how this.
And regarding what Subhash was saying, that we have different arterial territories. See, even in the different arterial territories, there are definite predilections for the arteries. We know lacunar arteries are affected, lacunar ones, vessels are affected by hypertension, and certain by this. So for an anterior spinal artery, the terminal branches, of course, it branches into two, one to the right, one to the left, and theoretically you can get affection of one. But then that disease has to be inside that one artery and not outside in the radicular, which is supplying the head. So there has to be something which is really badly compromising the artery going, the branch of the anterior spinal going to the left.
Sudhir, there is something called artery to artery embolism. Of course, in brain, maybe it happens here also.
Yes. So artery to artery embolism going into that one thing, yes. But was the onset so sudden?
Yeah, in fact, he complained. Sudden means he noticed one day, sudden. He noticed complained of pain on the right thigh, and same day he complained of the buckling in the left.
So could this be that something like your embolism of the?
Could be. That also is a possibility.
Because compression will not happen. Spondylotic compression will not happen so sudden.
No, not compression at all. Not at all compression. If at all, it can produce by nucleus pulpus embolism can go into that one area, or artery to artery embolism can go to one area.
Sudhir, now this has got me worried about my own back pain, and I'm now worried about any vascular complication.
Don't sit too long. Don't sit too long.
So shall I go to the next case?
Yeah. Okay. I think the last case.
Yeah, last case. It's a short case. 32-year-old lady has presented with acute onset of vertigo, diplopia, and ataxia 3 years back. This 3 years back, and she improved partially. Now admitted with worsening of the same symptoms. Again, vertigo, diplopia, pain came back. And look at the video of the patient. It's a short video. Asking him to look to the right and left. Look up. Looking to the left side. Looking to the right. Then looking at the eye spontaneously, you can look vertical movements up and down like that.
Can we see the pupils?
Pupil is normal. I only want to show the ocular movement. Look at the eye movement moving up and down, and the ocular movements. To show once again.
And the ataxia is only gait or limb also?
Gait ataxia. You cannot upward, you can move a little bit. You can move downward, but there is no lateral movement. Both eyes remain adducted. There is a vertical upward and downward movement of eye. Here you can see the upward and downward movement.
Sorry, Madhu. Did she have limb ataxia? Did she have limb ataxia or only gait?
Only gait ataxia. Limb ataxia is not, they're mildly but not very convincing. In fact, so what do you think the patient is having? That's all the story.
Yeah, interesting. Okay, so somebody please speak up.
Yeah, this only.
1 minute. Abdul Rahman has raised his hand. 1 minute. Somebody has raised his hand. Yeah. Dr. Abdul Rahman.
Sir, Perinode syndrome, dorsal midbrain syndrome.
Due to what? Dorsal midbrain syndrome, okay, but due to what? Recurrent dorsal midbrain syndrome.
B vascular.
No, but at a distance, why do you say midbrain syndrome? Her upward and downward movement is normal. She could not turn the eye laterally. That means
pseudo-abducens palsy.
Pardon?
Pseudo-abducens palsy.
No, what has happened to this patient is not pseudo-abducens palsy. Abducens palsy is subduction should be a palsy, it should be only, the eye should be in the primary position, only my restriction will be there looking to the other side. Where both eyes have gone inside.
Okay,
so, wait.
Sir,
Yes,
probably some demyelination involving the pontocerebellar region where PPRF is involved and
okay,
maybe
no, I'll tell you what.
No, let us see. Only lateral rectus palsy, but here the eyes are actively sort of convergent. Why is that?
Yeah, because I'll tell you one more. This is not episodic. Her eyes remain converged all throughout. That means the medial rectus has gone on to contracture due to the lateral rectus weakness. Any long-standing lateral rectus weakness, the eye goes into adducted position. She is not able to look abduct at all.
And why are the eyes moving up and down slightly?
Yeah, I'll come to that. Before that, so one thing is that she has got a bilateral rectus palsy. Second thing is that his eyes are moving up and down, as perfectly as Sudhir has told. What is that? Do you think it's a jerk nystagmus? It's not a jerk nystagmus.
It's not jerk. It was not in any...
bobbing?
It's not ocular bobbing. Bobbing is like fast downward movement and slow. It's not like that, going up and like. It's not regular. Sometimes irregularity is there.
It's going like this, very irregular up and down.
Correct.
Bobbing would be down and then slowly come up. Down and slowly come up.
Right.
But see, Madhu,
Yeah.
if we say why, I want to ask people, why did I ask about pupils? Is there anything which can, what can the pupils tell in this situation? There's one DD which nobody is talking about yet. Dr. Savali?
The perinods is one thing, and there is Q deviation as well.
No, it's not
No,
perinod.
no, something else I want to say. When
Right.
you see somebody with eyes like this,
You're thinking of
you must
what?
think of voluntary convergence spasm. So could this be functional, and could the person be doing convergence spasm? Now, if there's convergence spasm, you must look at the pupils. If the person is doing convergence spasm, his pupils will be constricted. And that may also, this going up and down could also be a voluntariness. So one possibility I still think could be functional.
Okay. Now the problem, what you said is correct. What Sudhir told is correct. But in convergent spasm, it's almost always episodic. It does not remain like that throughout. It continuously it will remain like that.
Yeah.
Moreover, in voluntary convergent spasm, they try to crank their convergence system. So what you usually observe is the screwing of the orbicularis. They're trying to contract their orbicularis in an attempt to converge. That comes episodically. So
Yes.
otherwise,
And
what
you can distract, like you said, Madhu is saying, you can distract the patient, look here and there, and that convergence, sometimes they will break. You will see a little bit change.
The other important simple bedside technique is that ask the patient to close one eye. If he's closing one eye, this phenomena will not be, convergent spasm so-called will disappear. So that's a simple bedside which he can do. But this was present all throughout. No change all the time. And she's trying to cooperate with you to try to examine. She's not at all able to move that. So this is very common thing. Probably you may not seen long-standing systemic palsy.
Okay. Some other people want to speak. So Dr. Pramod wants to ask, could this be bilateral INO?
No, bilateral, what is the problem is adduction failure.
Yes.
It is abduction failure. The eye goes into adduction. So just opposite to INO. Okay. In convergence retraction nystagmus, the eye episodically goes inside, goes up, back and inside. It's called episodically. Here the eyes remain adducted, continuously remain adducted. It's no question of a divergence coming here. Actually, convergent retraction nystagmus is not a nystagmus. This you should keep in mind. Because what is happening that all the extraocular muscles, predominantly made like this, co-contract, resulting in retraction backward. And what is happening is there's no slow phase in this thing, it's only relaxation. So that's not a nystagmus convergent, but it can be correctly seen in the Sylvian aqueduct syndrome in convergent retraction nystagmus. Now, this case, what is happening, the eye movement is what? As I said, it's a pendular nystagmus going up and down in irregular fashion. So I gave a clue. We had a bilateral 6th nerve earlier also. Second attack. This is called acquired pendular nystagmus and some rotary nystagmus also, which you couldn't make out. But what you could make out was a clear vertical pendular nystagmus. So this is due to the lesion in the Gillen-Muller triangle. You know what is Gillen-Muller triangle? The connection between the red nucleus, inferior nucleus, contralateral red nucleus, and back to this thing. This is, I think, I'll not spend time on this thing. So what investigation required? This is the MRI of the patient taken now. What do you find? You find normal, except the medulla shows in the region the two horizontal white band here, posterior to the perimeter tract, where the inferior olivary hypertrophic nucleus is situated. Now, a little more zoomed up view, you can find out the hyperintensity bilateral. Here again, and this is the pons showing a hemorrhage. Okay, this is the hemorrhage in the pons.
Oh, very nice.
And hyperdensity here in the anterior part of the medulla here.
There is no olivary hypertrophy.
No olivary hypertrophy. I'll come to that. Now, this is the cavernoma in the pons. What he had a bleed earlier. Now I come with the second bleed in the pons, producing bilateral lateral vesiculus. And the hyperintensity is in the region of the olivary. This is the bleed which has occurred now in the dorsal pons, affecting both sixth nerve. And this is the cover. The midbrain was normal. This is the SWI showing the bleed. Now, what is happening that we all expect hypertrophy of the olivary nucleus. But this hypertrophy is time dependent. It will not occur immediately after the insult. It will take 2 to 3 months later only hypertrophy will occur. We follow up that patient, the hypertrophy goes into atrophy. Hypertrophy disappears and become an atrophy of the inferior nucleus. So what this patient had was 3 years back had insult to the midbrain, to the pons, where the central technical tract is affected, inferior nucleus went into hypertrophy, but that is 3 years back. Now it's come with another episode, but the olivary nucleus has already gone on to atrophy. So this is from the literature. We can see the inferior olivary hypertrophy in the 2 to 3 months later. This is 20 months after the pontine hemorrhage. Axial putibate first spin echo at the level of IO in inferior nucleus shows hypertrophy and hyperintensity of the bilateral inferior nucleus. Follow up of the same patient 49 months after the hemorrhage, into a pontine hemorrhage shows hyperintensity in bilateral OIN, no evidence of hypertrophy, just like our patients with thin linear hyperintensity. This is our patient. This is from the literature. This is the old one. I mean the first MRI. This is second MRI. Showing this is the evolution of the hypertrophy. Does not occur immediately, occurs later, and subsequently goes into atrophy. So that's the case. So what the patient had was acquired penile nystagmus due to lesions on the central tegmental tract due to old pontine hemorrhage. Now, the other condition, which is MS, which can cause this kind of acquired penile nystagmus. Apart from conditions like Whipple's disease, their conditions like Whipple's disease. Any questions?
So Madhu, say it again. What was the etiology in this patient?
It's a pontine cavernoma with bleed.
Cavernoma.
You can see the cavernoma very clearly.
So yeah, we could see that. So what was done? Was it operated or something? Or no?
No, this was not operated because she improved and we sent home because this happened 3 years back, improved and went back. This time also she spontaneously improved. Nobody attempted a surgery in this stage.
Yeah, management is very controversial. Even in radio surgery, there are pros and cons.
These cases from medical college where I used to take classes, and the patients become a very poor patient. They cannot afford any of these things.
And the site is very crucial.
Okay, I think Madhu, great cases as usual.
Thank you. Thank you, Madhu.
Subhash, you want to end off?
Thank you. Thank you so much, Madhu, and thank you all the attendees, and thank you, Sudhir, most of all, for making this. I think these are wonderful cases. We really learned.
Nice. Very nice.
I thank Sudhir and Subhash once again for allowing me to present these cases.
No, I mean, it's our pleasure and everybody's luck.
Thank you, Sudhir.
Thank you. Thank you.
Thank you so much.
Thank you.
This Tuesday we got Dr. Mohit Bhatt speaking on Wilson disease, and it will be a pleasure to listen to him. So everybody join in at 8:30. We are not having the usual students program. We'll have Mohit talking on Wilson's at that time. So the fine program will not be there on this Tuesday.
Okay.
Thank you.
Sudhir, I just wanted to ask one thing. Can you hear me?
Yes.
Yeah. So yesterday I wanted to join that teaching program which you hosted, but I was not able to enter that thing.
I know many people could not. So I have sent out the link that they sent just now. If you want to watch that thing, I mean, the fun was in the live, but still you can just watch the webinar. It was good. And I've sent the link. You just click on that Zoom link and the password is also given. So you can watch it till I think 18th of October. For 1 month, they have kept it on. So you can watch it anytime.
Is there a second program coming up?
We hope to have it, and I shall try to get you to also put your cases there in that. Let's see. This was done by the Royal Society, and I had been telling them for some time, and we had invited Hardy and Raj. So hopefully they liked it, and maybe we'll have another one in 3-4 months.
Sudhir, please send to me also. I also missed it.
Yeah. So, okay, I'll send you that link. It was nice. It was fun. There were good cases, and basically it was like we are presenting the cases and they are trying to guess and discuss, and then they showed the cases. We were trying to. They were good cases.
Yeah, just like we are doing.
Yeah.
Yes.
That's fun.
It will be fun. Okay. Thank
Ask
you.
Ashish to send the link to me also, dear.
Yeah, I'll send the link now.
Thank you.
Thank you, sir.
Thanks. Bye.